Good evening, everybody. I'm Dr. Dennis Goodman, clinical professor of medicine at NYU and the cardiology department and our prevention department. Welcome to our Heart Health lecture series. Tonight, the topic is pregnancy and your heart. Next slide. Next slide. So the upcoming webinar that we have is Genetics in Heart Disease and Cancer, which is on Tuesday, December 10th. We have two great speakers, and please put that in your diaries. We look forward to seeing you. We're going to be talking about what screening can be done and should be done for cardiovascular disease and for cancer. This is just so that you can keep in touch with us. You can either use your phone to use this QR code now, or there's our address, which we give you every time we do these lectures, nyulangone.org/hearthealthlectures, or you can sign up for our e-blasts at hearthealth@nyulangone.org, and you will then be able to receive the lectures that we're giving. We also have a link to the YouTube channel, where we've recorded many of the previous lectures. We're doing our best to keep them current. And so if you miss a talk or you'd like to hear it again, or you'd like to refer your friends, you can listen to the talks on YouTube. We are very excited to say that we've had almost 100,000 hits on YouTube for the prior lectures and talks that we've given. So this is a very popular series, and I'm very proud of it. And I'm also very, very grateful to Anya Coates, who helps me make this all happen. This is just a logistic thing to let you know that I take questions, and we ask the questions at the end of the talk. So you can go onto the Q&A button at the bottom of your Zoom, and you can write in a question. I've already had several questions that have been sent in, so I'll try to get as many questions as possible. Next slide. So it's my pleasure and privilege to welcome Dr. Anaïs Hausvater, who is an assistant professor of medicine in the Leon H. Charney Division of Cardiology. She did her residency in internal medicine at Tufts, and then she did her cardiology fellowship at NYU. So we're delighted to have her as part of our faculty. She is the co-director of the Postpartum Cardiovascular Health Program. Her clinical practice focuses on women and cardiovascular disease, and also on women and related to pregnancy. And she treats a lot of women who are pregnant and with other cardiovascular conditions. So we're going to give you, at the end of her talk and at the end of this lecture, we will tell you how to get hold of her. She is a fantastic clinician, and she's a great speaker and a great lecturer. And I could think of no one better to talk to us tonight about pregnancy and your heart. I just want to just say up front that we specifically I wanted her to focus on common issues during pregnancy, which is most predominantly hypertension. So we're not going to focus on congenital heart disease in pregnancy. That's another story. And if any of you have interest in that, and you send us an email, we'll definitely put you in touch with our cardiologists who focus on congenital heart disease during pregnancy, those pediatric cardiologists. So welcome, Anaïs, Dr. Hausvater, and I'll hand it over to you.
Thank you so much. Can you see my slides okay?
Yes, look good.
Great. So thank you, Dr. Goodman, for the invitation to speak with you all tonight about a topic that is one of my favorite things to speak about. And I really appreciate everyone who is attending. I know some of you are probably mothers of young children, and that, it takes a lot at 5 p.m. to, learn about how you can optimize your health. So I really commend you for that. Okay, so my goals for this talk are to tell you about how pregnancy affects the heart, what are hypertensive disorders of pregnancy and who is at risk, how to treat high blood pressure in pregnancy, what are the risks to the heart after a pregnancy that is complicated by high blood pressure, how we can reduce this risk and improve cardiovascular health after pregnancy, and what you can do if you're planning for your next pregnancy after having had a complicated pregnancy. So some of you might be wondering why a cardiologist is talking to you about pregnancy. Now, unfortunately, we have a maternal mortality crisis in this country, and maternal mortality rates are rising in the US. Cardiovascular disease is the leading cause of maternal deaths during pregnancy and in the postpartum periods. Adverse pregnancy outcomes, particularly hypertensive disorders of pregnancy, which I'll be talking to you about, but also gestational diabetes and preterm birth are key risk factors for maternal death and predict future cardiovascular disease. Now, in part, this is because the cardiovascular health of women who are entering pregnancy is worse than it ever was before. Women are entering pregnancy older with more cardiovascular risk factors like obesity, high blood pressure, and pre-existing heart conditions. Now, in general, pregnancy is a very big stress on the heart and the whole body. Pregnancy is often considered nature's stress test on the heart that can unmask heart disease that was already there. During normal pregnancy, even in the best of circumstances, women experience an increase in their blood volume, an increase in heart rate, and an increase in cardiac output throughout pregnancy, which is the amount of blood your heart pumps every minute. And by the third trimester, your cardiac output needs to increase by up to 50%. So this is, your body's working really hard during pregnancy. Now, what is pregnancy-related high blood pressure or hypertensive disorders of pregnancy? There is a spectrum. And when we talk about pregnancy-induced hypertension specifically, we use the 20-week cutoff, so 20 weeks of pregnancy as the cutoff. So if you have high blood pressure or hypertension before 20 weeks, you're considered to have chronic hypertension. So it's assumed that you probably had high blood pressure before pregnancy. After 20 weeks, if your blood pressure, if the top number is more than 140, bottom number more than 90 on two separate occasions, then you are considered to have gestational hypertension. And you're diagnosed with preeclampsia if you have high blood pressure at the same cutoff on two occasions, or if you have severe high blood pressure, so top number more than 160, bottom number more than 110, and if you have protein in the urine or evidence of end organ dysfunction. And there's a bunch of different lab cutoffs that we use. There's also severe preeclampsia. And severe preeclampsia is defined when you have severe high blood pressure, so top number more than 160, bottom number more than 110, again, spaced 4 hours apart, and or evidence of end organ dysfunction. Eclampsia is a severe form of preeclampsia where you can get seizures. There's also an associated condition called HELP syndrome, which is where you have evidence of hemolysis, which is your red blood cells breaking down, high liver enzymes, meaning you have some dysfunction of your liver, and low platelets. And then you can have chronic hypertension, meaning high blood pressure before 20 weeks, and then you can develop preeclampsia, and we call that superimposed preeclampsia. So how common are these? Unfortunately, they are very common. So we see hypertensive disorders of pregnancy occur in anywhere between 5 to 15% of pregnancies worldwide. And here at NYU, it's even higher because we see high-risk patients. And we see that these conditions are rising in prevalence. The rates are highest among Black mothers, and the rate of pregnancy-related high blood pressure has doubled in the US in the last 10 years. And in addition, up to 14% of pregnancies are complicated by gestational diabetes. Now, who is at risk for high blood pressure during pregnancy? So we tend to divide or categorize risk factors into highest risk, moderate risk, and low risk. High risk are those who have had preeclampsia before, who have diabetes before pregnancy, who have an autoimmune condition like lupus, who have chronic hypertension before pregnancy, multi-fetal gestation like twins or triplets, and chronic kidney disease. Then there are these moderate risk factors, and those include if it's your first pregnancy, if you have obesity or a BMI more than 30, if you have a family history of preeclampsia in your mother or your sister. And then there are some socio-demographic characteristics like if you identify as Black race or have a low socioeconomic status. If you've had a prior pregnancy that was not complicated by high blood pressure, but something else like preterm birth. If you are more than 35 years old, or if you've had a prior pregnancy, but it was more than 10 years before. Low risk are those who have already had one healthy pregnancy within 10 years. We use these risk factors to decide who should take a baby aspirin because baby aspirin is one of the best tools we have to prevent preeclampsia. So if you have one high risk feature, then you should take an aspirin. If you have two moderate risk factors, you should also take aspirin. If you're low risk, aspirin is not recommended. So why do we take aspirin? Aspirin works two ways. It has anti-inflammatory properties, so reduces inflammation, and it's also an antiplatelet agent, which means it binds to platelets. Platelets are factors in our blood that are sticky and can cause blood clotting. Studies have shown that low-dose aspirin, so at a dose of 81 to 100 milligrams, in the US we use 81 milligrams, can prevent preeclampsia, and if it doesn't prevent it, it can often delay preeclampsia. It can also prevent stillbirth, fetal growth restriction, and preterm birth. Preterm birth is usually birth before 34 weeks. Now, aspirin should be started for preeclampsia prevention by 12 weeks of pregnancy. And in the studies, the highest benefit was when women took aspirin before 16 weeks of pregnancy. And the good news is that studies have shown that aspirin's pretty safe in pregnancy. So it has not been shown to have a high bleeding risk or any adverse effects to the fetus. And really the only people who are high risk and recommended for aspirin who shouldn't take it are those who have, severe allergies or severe asthma. Management of high blood pressure during pregnancy. So the first consideration when we're thinking about how to manage high blood pressure is how severe the blood pressure is. If it's extremely high, so if the top number is more than 160, bottom number more than 110, that's when you really should go to the hospital and be treated with IV medications. If you have chronic hypertension, top number more than 140, bottom number more than 90, we typically treat you with one of two agents, labetalol or nifedipine. The reason is that that's what's available in the US. There's another medication called methyl-dopa that's not very easy to get in the US. But those are the two medications that are considered safest during pregnancy. Although there are others that are also safe. These are kind of the ones that have been most studied and most widely used. There are certain medications you'd want to avoid, certain blood pressure lowering medications. So there's a class of medications called ACE inhibitors. You'd want to avoid those. That's like a medication like lisinopril or losartan. Atenolol is another medication that is not considered safe. Same with spironolactone. If you're on any high blood pressure medications and you're thinking about getting pregnant, it's best to just talk to your doctor to see if you're on one of the medications that are considered safe. Now, if you are diagnosed with severe preeclampsia, oftentimes you'll be treated with IV magnesium, and this is to reduce your risk of seizures or development of eclampsia. Also, if you have preeclampsia, the obstetricians will often deliver you potentially earlier than letting you go all the way to term, because this has also been shown to reduce the risk of end organ dysfunction. There's a really important study that was done in 2022 called the CHAP trial, which really changed how we treat chronic hypertension in pregnancy. Prior to this trial, oftentimes the OBs would kind of let patients with high blood pressure, they would tolerate a high blood pressure until it got over 160, over 105, 110, and really only at that point would they treat with medications. This study compared more aggressive treatment to a goal less than 140 over 90. And they showed that, in fact, if you're more aggressive and you lower blood pressure more, and blood pressure is better treated in pregnancy, then you can reduce the risk of preeclampsia, placental abruption, or fetal death, or preterm birth. And they also looked at safety outcomes, which included the risk of having a small for gestational age baby. And that was really prior to this study, the biggest concern with regards to treating blood pressure more aggressively. So because of this trial, we know that we want to get your blood pressure below 140/90 when you have chronic hypertension and you become pregnant. Now I'm going to shift to talking about what is the risk once you've had a high blood pressure disorder during pregnancy. So as you can see here, hypertensive disorders of pregnancy do significantly increase risk. The highest risk is the development of chronic hypertension, which can be up to 3 to 4-fold higher among those who have had hypertensive disorders of pregnancy. But there's also a risk of other things like coronary artery disease, stroke, heart failure, as well as an increased risk of death. So, these are kind of really scary outcomes that we want to avoid. And the risk can be even higher among those who have had recurrent pregnancies complicated by preeclampsia, so who have had preeclampsia more than once. For those patients, it can be up to 2 times higher in terms of risk than those who have had only preeclampsia in their first pregnancy. The good news is that studies have shown that about 60% of the excess risk of cardiovascular disease can be explained by the development of other cardiovascular risk factors like diabetes or hypertension. And the reason I say this is good news is because these are treatable conditions. And the last thing I want to mention is that studies have shown that hypertensive disorders of pregnancy remain an important risk factor even up to 50 years after pregnancy. So if you are, 45 years old and you're seeing a doctor for the first time, it's important to mention this, even if it's been, many, many years since your pregnancy. Now, the biggest risk that we worry about in the first year after pregnancy that's complicated by preeclampsia is the risk of chronic hypertension. We know that in the first year after hypertensive disorders, the risk is 25 times higher if you've had a hypertensive disorder of pregnancy compared to those who did not. And in fact, we see that the incidence of chronic hypertension, which means high blood pressure beyond 6 months after pregnancy, can be as high as 30 to 40%. It's even higher if as you increase in age. And the risk is highest if you have obesity, so a BMI more than 30. The incidence of chronic hypertension goes up to 60%, which is really, really high. You can see here on the right, again, comparing different age groups over time, those who are oldest and had a hypertensive disorder of pregnancy have the highest risk. Now, we also see from other studies there's evidence of early coronary artery disease and early heart attacks after hypertensive disorders of pregnancy. Atherosclerosis is what you see here on the right. It's a buildup of plaque in the heart arteries, which can lead to heart attacks. And studies have shown that women who have had prior preeclampsia have 1.4 times higher odds of having atherosclerosis compared to those who did not. Other studies have shown that preeclampsia can be associated with an earlier heart attack, up to 5 years earlier than those who did not have preeclampsia. So taken together, these data suggest there's this phenomenon of premature vascular aging among women who have had preeclampsia history, which means that your blood vessels look 5-10 years older than they should. Now, you might be wondering why. Why do women with adverse pregnancy outcomes develop cardiovascular disease? And this is kind of a question I'm always wondering, and patients are asking me, is it the chicken or the egg? Did I have something there that was unmasked during pregnancy, or is it the pregnancy complication itself that's increasing my risk? And the answer is probably that it's a little bit of both. We know that women who already have cardiovascular risk factors going into pregnancy are at highest risk. But we also know that something happens during the pregnancy, particularly during the formation of the placenta, that is the inciting event for preeclampsia development. And we see that there's this cascade of events that leads to vascular damage and inflammation. And this can persist years after delivery. So some of you might also be wondering, how come I've seen doctors and they've never told me about this before? We've seen in some survey studies that unfortunately there's a big knowledge gap among doctors regarding the risk of future cardiovascular disease after hypertensive disorders of pregnancy. And there's some differing of knowledge based on the specialty of the doctor and even the sex of the doctor. So We've seen from studies that OBGYNs and internal medicine doctors, a majority, more than 50%, reported being unaware that a hypertensive disorder of pregnancy was associated with all of these cardiovascular diseases that I mentioned. And there is a sex difference here. So the female doctors tended to know this connection more than the male doctors. So basically what I'm trying to say is that if you go to see a doctor and they don't ask you about your pregnancy history, you should tell them anyways, because you now know, based on this talk, that it's important when we're assessing your cardiovascular risk. So what can we do to reduce the risk of hypertensive after a hypertensive disorders of pregnancy? So as I mentioned, the biggest risk that we worry about in the immediate term is the development of chronic hypertension. So monitoring your blood pressure at home can be one of the best things that you do. One study showed that up to 42% of those who had preeclampsia had persistent hypertension at 1 year. And 17% of those cases were only detected when patients were monitoring their blood pressure at home. When they were going into the office, it was normal. So that's actually something we call masked hypertension, which is the opposite of what you might have heard of as white coat hypertension, where your blood pressure is higher in the doctor's office. So I tell my patients, if your blood pressure is normalized after preeclampsia, you're off medications, you should still check your blood pressure maybe once a month, once every 2 months. And if it's high, then you should call your doctor. In terms of deciding about when to wean medications, I usually wait until the blood pressure is normal, consistently less than 120s over 80s. And if the blood pressure is consistently high, more than 130s over 80s, that would be a reason to up titrate medications or start medications if they have not yet been started. So in terms of cardiovascular prevention outside of the hypertension that I mentioned, it's really all about screening. So we want to check your blood pressure, your weight. We want to screen you for diabetes. We want to screen your cholesterol. And this should really start at about 3 months postpartum or beyond. In the immediate term postpartum, the first kind of few weeks postpartum, the focus is really blood pressure management. And after that is when we should really focus on, cardiovascular risk assessment. And that can be done by a primary care doctor or a cardiologist like myself who specializes in this, or really any cardiologist. So I want to introduce this concept of life's essential 8, which is what I speak to my patients about in terms of how we can modify our cardiovascular risk. So this is a concept that was put out by the American Heart Association as a construct for optimal cardiovascular health, and it includes 8 modifiable factors, which includes healthy diet, exercise, blood glucose, BMI or weight, cholesterol, blood pressure, smoking, and sleep. And when optimized, all of these factors can reduce your risk of cardiovascular disease. And unfortunately, only less than 1% of the US population actually meet criteria for ideal cardiovascular health based on these metrics. So what is blood pressure, you might be wondering? So blood pressure is the force against which your heart needs to pump to circulate the blood. The systolic blood pressure is the top number, is the pressure when the heart beats. And the diastolic pressure, which is the bottom number, is between heartbeats. And when blood pressure is high, also called hypertension, the heart has to work harder and the arteries are under greater strain. So imagine when you go to the gym and you're trying to build up, your bicep muscle with weights. The heart responds the same way when it sees a high blood pressure. It can get larger. It's important to know when we're talking about blood pressure, how to actually take your blood pressure, especially if you're checking it at home. We want to make sure that you have a proper technique. So before you check your blood pressure, you have to make sure that the cuff you're using is well validated and that it fits well around your upper arm. You want to empty your bladder. You want to avoid caffeine, smoking, or exercise 30 minutes before. You want to remove any clothing that's covering your upper arm. You want to sit. You want to put your arm on the table at the level of your heart, like in this picture. And if you're keeping kind of a blood pressure log, you want to try to do it around the same time every day. It's good to sit upright in a chair, to have your legs uncrossed, and to have your feet on the floor. So, I've already obviously alluded to this, but high blood pressure is really bad for the heart. and it's really common. 47% of US adults have high blood pressure. And it's termed the silent killer because it really doesn't cause any symptoms at all until it's extremely high and until it's caused a lot of damage. And the risk increases for women after menopause or after, obviously, a hypertensive disorder of pregnancy, like we've been talking about. And women who have hypertension have a higher risk of heart attack, heart failure, and death from complications of their high blood pressure. So who is at increased risk other than what we've talked about, having had a hypertensive disorder of pregnancy, older age, if you have a family history of hypertension, if you identify as Black race, if you have obesity, if you have a high sodium diet or high alcohol diet, if you have a sedentary lifestyle, or if you have insufficient sleep. And why should we treat hypertension if it doesn't cause any symptoms? Hypertension can cause a lot of damage to different organs in the body, can cause a stroke, can cause vision loss, heart failure, heart attack, kidney disease. And the good news is that treating the hypertension can reduce your risk of these things significantly. And people who have high blood pressure live longer when they're treated appropriately with medications. It's important to know your numbers. So the numbers I told you about during pregnancy are different than the numbers we talk about for chronic hypertension. So normal blood pressure is when the top number is less than 120 and the bottom number is less than 80. Elevated is when you're between 120 to 129 over less than 80. And hypertension starts when the top number is more than 130, bottom number is more than 80. That's stage 1. And stage 2 is when the top number is more than 140 and the bottom is more than 90. Now, blood pressure can be treated with some lifestyle interventions like weight loss, healthy diet, reducing sodium in your diet, increasing potassium, increasing physical activity, and reducing alcohol, in addition, of course, to medications when they're needed. Now, I'm going to talk about weight because weight is a really important way you can lower your cardiovascular risk. It doesn't take a lot of weight loss if you are overweight or obese to have improvements in cardiovascular risk factors like blood pressure, cholesterol, and glucose. Weight loss can delay the onset of diabetes and again can really improve blood pressure. And weight loss is hard. It's really hard to do, especially when you're postpartum. And in some people can be done by optimizing diet and increasing exercise. But you have to reduce your caloric intake by about 500 calories a day from baseline on average, and it somewhat depends what weight you're starting at. But some individuals may benefit from weight loss medications or bariatric surgery. Now, exercise is also really important for your heart health. And again, I'm a mom of 2. I fully realize how hard it is to have any time for exercise. The American Heart Association recommends 150 minutes per week of moderate to high intensity exercise, which seems like a lot, especially if you're a mother of young children. But the good news is that even 10 to 15 minutes per day has shown benefit. And what I tell my moms is that postpartum exercise can look different. You're not going to have an hour to go to the gym every day like maybe you used to have before. Maybe you do, and if you do, that's great, but most people won't. So lower your expectations about what you consider to be exercise. You don't even need to wear exercise clothing. It doesn't need to be at a gym. It can be at home. Stroller walks, carrier walks, those count as moderate intensity exercise. Exercise with your baby, or exercise while your baby's sleeping, even if it's 15 minutes during your baby's nap. Leave your kitchen. Your kitchen can be a mess. Just get 10 minutes in of exercise, and that's really good for your health. And then I try to tell my patients by about a year postpartum is when you really want to try to make sure that exercise is incorporated into your lifestyle. In addition to exercise, it's important to avoid prolonged sitting. So a lot of patients who have jobs where they work from home or who have, office jobs where you're sitting at a desk all day, that could be really detrimental to your heart health as well. So you want to try to sit less. You want to try to get up at least once an hour. Set an alarm on your phone, or, there's a lot of wearable devices that will ping you if you're sitting too long. Limit TV time. Try to take the stairs when possible instead of an elevator. Get off the bus or the subway, stop early so you can walk. do a meeting while walking, try to be creative. So diet obviously is really important for heart health, and this is like a whole lecture on its own. But the DASH diet is what's recommended for heart health after hypertensive disorders of pregnancy. If you do have hypertension, you do want to try to limit your sodium intake. And really, you just want to try to focus on fresh foods, fruits and vegetables, avoid packaged processed foods as much as possible, avoid fatty meats. Try, if you're eating carbohydrates, try to avoid, white carbohydrates, simple carbohydrates. Try to incorporate whole grains. Fish is really healthy, some poultry, and plant-based proteins like beans, tofu is really healthy. Also trying to incorporate healthy fats like olive oil, avocados, etc. Some kind of healthy eating hacks for moms that I came up with that I tell my patients. Meal prepping or planning ahead is really important because you might not have time during the week, especially if you're a working mom. So try to do some meal prep on the weekends. Try not to skip meals or avoid snacks, because if you get too hungry, then you'll make poor choices. So pack some healthy snacks. Avoid diets. Diets don't work. This is a healthy lifestyle that you're aiming for. Trying to get protein, healthy fats, and fiber with every single meal so that you can stay full. The idea is just avoiding being very, very hungry, because when we're really hungry, we just make poor choices. Other things that have nothing to do with eating can improve your diet. Focusing on stress reduction and sleeping well is really important to regulate appetite. Try to eat healthy as a family. Sitting with your child and eating with them, even if it's early, can be healthy for you as well, and can also help your child become better eaters. And avoid late night eating. I see very often my patients will, get their kids ready for bed, do bath time, put their kids down, and then once their kids are down, they'll eat like, second dinner or ice cream or whatever it is. And I think that is one area that can be improved for a lot of patients. So blood glucose screening for diabetes is really important, because diabetes is very strongly associated with heart disease. If you've had a hypertensive disorder of pregnancy, I recommend getting a hemoglobin A1C done at least once a year. If your A1C is between 5.7 to 6.4, this is considered pre-diabetes. So this is a red flag that you're at high risk of diabetes. If your A1C is more than 6.5, you do have diabetes. What about cholesterol? So you might have heard about good and bad cholesterol. LDL is considered bad cholesterol, builds up in the arteries and causes plaque formation. Higher is worse and lower is better. HDL is good cholesterol. It helps remove bad cholesterol from the arteries. And lipoprotein A is a genetically inherited form of bad cholesterol. It's a large lipoprotein like LDL, and it's sticky. It sticks to blood vessels, and it's a marker of high cardiovascular risk. So I do recommend getting a regular lipid panel, but also getting your LPA checked at least once. Do you need cholesterol lowering medications? Well, it depends. These are the guidelines we use in cardiology, but they're really insufficient for most of my patients, because the risk assessment we use really underestimates risk if you're a young female. However, the guidelines do suggest using risk-enhancing factors to help with your decision, and one of the risk-enhancing factors they call out is preeclampsia. So how can we better predict risk? I mentioned that a lot of risk calculators that we use in cardiology underestimate the risk in young women. The most common one that we use in cardiology is a 10-year risk prediction tool that is not very helpful for my patients who are, 35 or 40 years old. Sometimes we have to use a 30-year risk prediction or a lifetime risk prediction. Sometimes it can be helpful to look for what we call subclinical atherosclerosis, which means you already have plaque building up in your arteries, even if you don't have any symptoms. If you're more than 45 years old and you have high cholesterol, a CT calcium score might be helpful, which is shown here on the right. It's a low radiation CT scan that can pick up calcium, which sticks to plaque. If we do see calcium in your arteries, we will often recommend a statin or a cholesterol lowering medication. For even younger patients, they might not have had time to build up calcium yet, so the calcium score might not be helpful. Sometimes a carotid ultrasound can be helpful, again, to look for premature atherosclerosis. These tests can help guide your doctor about whether we need to be more aggressive with lowering your cholesterol. So I know it sounds ridiculous to talk to moms about sleep health, but sleep health is really important. And I think most of my patients are never counseled about sleep health because it's just assumed if you have a baby, you're not going to sleep well. But I'm here to tell you that it's important and you should worry about it. Obviously when you have a newborn, you're not going to be sleeping well and you will have interrupted sleep. But even despite that, you should still try to get total sleep hours, somewhere between 7 to 8 hours. And here are some tips for a better sleep. Turn off your screen 1 hour before bed, have a consistent bedtime routine, avoid eating within 2 hours, limit caffeine. If you have sleep disordered breathing like sleep apnea, should be treated, manage your stress. And when it is developmentally appropriate, it's important to really focus on your child's sleep because if your child is sleeping well, you will sleep well. Okay, what about your risk of a hypertensive disorder in future pregnancies? I mentioned if you've had preeclampsia before, your risk of having preeclampsia again is higher, anywhere between 20 to 50%. It's even higher if you had a severe form of preeclampsia. So if you had preterm preeclampsia, your risk is higher. And the risk of having preeclampsia again in another pregnancy increases if it's a multiple gestation, meaning you're pregnant with more than one baby, like twins. If you have chronic high blood pressure, if you have diabetes, if you have kidney disease, if you're obese, if your age is more than 35, if you have PCOS, if you have lupus or another autoimmune disorder, if it's an IVF pregnancy, if you have sickle cell disease, or if you identify as Black race. How can you improve the health of a future pregnancy? So we see in studies there's a consistent association between pre-pregnancy cardiovascular health and the risk of these bad pregnancy outcomes. So optimizing your heart health using all of the tools I just showed you will improve the health of your next pregnancy and reduce your risk of preeclampsia. I mentioned obesity many times because weight loss is really important. Being at a normal BMI or targeting a normal BMI prior to pregnancy can significantly minimize your risk, as well as reducing gestational weight gain, so how much weight you gain in the pregnancy. We already talked about low-dose aspirin. Starting that by 12 weeks can reduce your risk as much as 20% or more. Treating chronic hypertension to a lower blood pressure target to less than 140 over less than 90, as I mentioned from the CHAP trial. Spacing out your inter-pregnancy interval, so trying to have a next baby after a preeclampsia pregnancy no sooner than 12 to 18 months. And then there's a lot of studies that are going on right now about kind of newer modalities. There's studies looking at statins or metformin to reduce the risk. And we don't have kind of the evidence yet, but there's a lot of research being done in this field. So as mentioned, I have a postpartum cardiovascular health clinic. So what do we offer? We screen you for blood pressure. We can offer remote blood pressure monitoring where appropriate. I educate my patients on the long-term cardiovascular risks, like I've done today. And we do comprehensive cardiovascular health counseling that's tailored to the postpartum period. We assess your risk for cardiovascular disease. We manage any cholesterol disorders or lipid disorders. If you've had high blood pressure for a really long time, sometimes I'll do a workup for reasons why you might have high blood pressure. We help with obesity management. We have an amazing nutritionist who's helped a lot of my patients with meal planning and weight loss. And then any further cardiac testing that might be needed, like some of the ones I mentioned, like the calcium score, and then some preconception counseling. So when some of my patients who have had preeclampsia are planning their next pregnancy, I will kind of help guide them on that as well. So some key takeaways from today: hypertensive disorders of pregnancy are really common. They increase risk of cardiovascular disease. Low-dose aspirin should be taken by 16 weeks of pregnancy for those who are at high risk, ideally by 12 weeks, but no later than 16. Optimizing cardiovascular health after a preeclampsia or hypertensive disorder can reduce your risk of cardiovascular disease and also help the health of a future pregnancy. And risk of recurrent preeclampsia can be reduced by aspirin as well as optimizing cardiovascular health. So this is the information to contact our program. This is one of my patients who's now had 2 beautiful babies that are healthy. And that's all I have. So I'm going to turn it over to Dr. Goodman. Thank you very much.
Thank you so much, Dr. Hausvater. That was fantastic and comprehensive, and you covered all the good stuff. So I really appreciate it. And I think there are a lot of people that are interested, not only because they're interested in the pregnancy part of it, but it's about being healthy, whether you're pregnant or not. And you really are, right on track in terms of what our prevention center is all about, which is how to keep people healthy and using lifestyle changes, which is so important. I just wanted to, one or two questions came in. I wanted to just clarify something. Someone asked about the calcium score during pregnancy. I think you just want to emphasize we're not talking about doing these tests while you're pregnant.
Yeah. And we don't even check cholesterol when you're pregnant because the pregnancy itself affects your cholesterol. So these are things that we're using to assess your risk after pregnancy. The earliest would be 3 months postpartum.
Now, what about women that have high cholesterol? They're on a statin and they tell you they want to become pregnant. How long would you tell them to stop it for?
Yeah, so in general, the recommendation is to stop your statin if you're planning on becoming pregnant. But there are some rare exceptions where the risk of stopping the statin outweighs the risk of being on a statin. And those are if you've had a heart attack already, if you have a stent, or if you have severe high cholesterol from something like familial hypercholesterolemia. Everyone else, typically, I would say, about a month to 2 months before.
Okay. I'm actually very interested in holistic integrated medicine, and magnesium is one of those things that I found very helpful. I don't know whether you recommend it to patients, but I've had many patients who have managed to treat their hypertension, especially when it's mild or moderate, just with lifestyle changes and taking magnesium every day.
Yeah, you know what I do? I recommend all the time, and I take it myself because it helps you sleep. And I took it throughout my pregnancy for sleep, but it has a lot of benefits too. Can help with extra heartbeats. So yeah, I do find it something I recommend pretty often.
And we do use it intravenously in patients with severe hypertension during
Right.
Pregnancy as well. So it's very, very helpful. So let's go through some of the questions that people sent in, and then I've got a few that came in as well during your great talk. Who should see a cardiologist before conception?
So anyone who has a diagnosed cardiovascular disease should see a cardiologist. So that includes like a valve problem, congenital heart disease, if you've had a heart attack, if you have severe high blood pressure, if you have very high cholesterol, any of those would be a reason to see a cardiologist. If you're a healthy person, I would say just see your primary care doctor. And if you're on any cardiac medications, definitely would see a cardiologist before conception.
Okay. Next slide. Well, the question that I just passed over is that people should have a cardiology checkup before, pregnancy. And I think that your physician, your primary care physician can take care of that. And a general checkup is really a good idea. I don't think you need to see a cardiologist unless there's a cardiology problem. Next slide. Other than aspirin, are there any ways to prevent recurrence of preeclampsia in subsequent pregnancies?
Yeah, so I kind of touch on this, but I would say the two best things you could do would be to optimize your cardiovascular health, and that includes optimizing your weight, making sure you're eating a healthy diet and exercising. And then the second thing would be if you have chronic hypertension already, making sure that your blood pressure is well controlled going into that next pregnancy.
Okay. What is the increased rate of heart disease for people who have preeclampsia more than once?
Yeah, so having a second or a third episode of preeclampsia after you've had it in your first pregnancy can more than double the cardiovascular risk. So there is an increased risk if you have it multiple times.
Okay. Next slide. How do we maximize heart health in a second pregnancy after preeclampsia? In the first, I think you've covered that, but do you want to add anything?
Yeah, so really it's
You could be
aspirin,
even more aggressive.
optimizing heart health, it's making sure your blood pressure is well controlled, and then the interpregnancy interval, spacing out the pregnancies by more than 12 months.
Next slide. What steps can women take to prevent complications later in life after having preeclampsia?
Yeah, so one thing that I really wanted to stress was that, studies have shown that up to 60% of the increased risk comes from development of other cardiovascular risk factors, meaning you had a hypertensive disorder of pregnancy and then you got hypertension, you got diabetes, you became obese, you got metabolic syndrome. So if we prevent and treat those conditions, we can likely prevent most of the cardiovascular disease that I'm speaking about. So that's really what we focus on. Those are the modifiable cardiovascular diseases that I think would really prevent risk.
Next slide. How long should you be off Adderall or Wellbutrin before getting pregnant to avoid cardiovascular issues during pregnancy? I'll just say that both Adderall and Wellbutrin, it's inconclusive as to whether they have an effect during pregnancy. Most of the time, we try to get people off medication, and it's very important that you talk to your physician about what medications you're on. I don't know whether you want to add to that, but you can't just stop the medications. You need to talk about it, and sometimes there are safer alternatives that you can be switched to, but it's always about the risk-benefit ratio. So whatever medicines you're on, whoever wrote for them, whichever doctor needs to discuss it with your obstetrician.
Yeah, I completely agree with that. And the one thing I will add is that the same is true if you're a reproductive age woman who might not be planning a pregnancy but is on a medication. If that medication is not safe for pregnancy, you really want to make sure you're on contraception because, surprise pregnancies can happen, and that can be dangerous if you're on some of these medications that are unsafe for a fetus. So whenever I'm starting a medication in a young woman or a reproductive age woman, I counsel them that they have to be on contraception.
Okay, thank you. Next slide. Could you share more about long-term hypertension postpartum and what factors could trigger that? I think you've covered that, but do you want to just summarize it quickly?
Yeah, so as I mentioned, the risk of chronic hypertension is 25 times higher if you've had a hypertensive disorder of pregnancy. And the other two big factors that increase your risk are age. And the second one is obesity or being overweight. So that's why when I see patients, I really try to emphasize weight loss because weight loss is good for cardiovascular health for many reasons, but it's also one potential treatment for hypertension. And sometimes it can be really uncomfortable to talk to postpartum patients about weight loss because it's a really sensitive topic of conversation and it's a sensitive time. But I recommend that by at least a year postpartum, you want to try to get to a normal weight.
There was a recent article in Circulation that was really interesting, showing that they looked at middle-aged women and they followed them for 5 years, checking their blood pressures, and then they took the average blood pressure over 5 years and then followed them for 10 years. And they looked at which ones managed to reach the age of 90. And it was very clear that the ones between a blood pressure of systolic between 110 and 120 were more likely to get to 90, and ideally between 110 and 120, but 110 to 130 was a group that did well. And so it's just to your point, it's such an incredibly important risk factor. And it's important that, and I think we're all learning now as doctors that we want to be more aggressive and not accept 140 over 90 or 160 or 150 over 90, because the studies are clear now that if you can keep the blood pressure lower, provided that you're not symptomatic and you're not falling, it's better to have a lower blood pressure on medication than to not take medication and be with a higher blood pressure.
Yeah, you bring up a really good point. Actually, a study that came from NYU showed that patients who had a blood pressure in their first prenatal visit that was above 114 systolic were at higher risk of developing hypertensive disorders. So to your point, the blood pressure thresholds we should be using are probably much lower than what we are using now. And the OBs are even further behind us. in terms of their management of blood pressure.
I hate to say it, but when I was at medical school, I'm talking, 50 years ago, 45 years ago, we used to, we were taught that the blood pressure systolic could be the patient's age plus 100. So we would accept in a 70 or 80-year-old a blood pressure of 170 over 80, and you just realize over time what a mistake that was. And so a lot of people were living with high blood pressure, and it was thought to be acceptable because it was felt to be, quote, normal. But in fact, it was doing them a lot of harm. So be cognizant of your blood pressure and check it. And it's very, very treatable, in my opinion, when it's mild and moderate with lifestyle changes, DASH diet, and you may never need medication. I told you magnesium's helpful if you get to take care of it early on and you develop these good, healthy habits. Yeah. So one of my regular attendees here, I won't mention his name, but he's always there and he always asks lots of questions. I'll summarize one or two of them. He wants to know about viral infections during pregnancy. Is it a risk factor for eclampsia, such as CMV?
That's a really good question. I haven't seen that as a risk factor, and it's not considered one of the risk enhancers. So I think
I'm not aware of that either. Yeah. I mean, I think women get viral infections during pregnancy, but for the most part, they're benign and they don't affect the blood pressure. Mm-hmm. Is there a supplement that you recommend during pregnancy, just a multivitamin that we give women, or is there anything specific? And would you tell them to avoid specifically any medications? He mentioned that atenolol and ACE inhibitors. Obviously, we want to try to avoid as many medications as we can. We mentioned the fact that you should discuss it with the doctor, and we try hard to take people off medications that they don't absolutely need. But in terms of supplements?
Yeah, so supplements, I mean, everyone should be on a prenatal vitamin. In terms of like the composition of the prenatal, there's no real good evidence to suggest that one prenatal is better than the other. Some of them have iron that obviously are good for those who are iron deficient. We talked about magnesium, which I do suggest because you can get a lot of insomnia during pregnancy, so it's helpful for sleep. And then in terms of medications, as I mentioned, the two most common ones are nifedipine and labetalol because those are the most well studied and considered the safest. Methyl dopa as well, but that's not widely available in the US. And then, there are some medications that are definitely contraindicated, like an ACE inhibitor or an ARB, as you mentioned. Spironolactone or atenolol are the ones that we try to avoid.
How about IVF? Any increased risk in that situation?
Yeah, we definitely do see increased risk of preeclampsia and hypertension in IVF pregnancies. And we don't know still if it's the IVF itself or is it the fact that there's something to do with the infertility that increases risk. But one thing I'm seeing a lot is older patients who do IVF and use donor eggs have very, very high blood pressures.
Okay. And in terms of fasting during pregnancy, intermittent fasting, not a good idea. I think we're going to agree with that. Healthy diet, you made it very clear. You should have regular meals, 3 meals a day, and a healthy diet. So on that note, I'm going to say thank you so much. It is an outstanding talk. I'd like to just put up your information here. So Dr. Hausvater is a cardiologist. She sees mainly women, but she'll see men as well. And she has real expertise in women's health and women and pregnancy. So there's the phone number to make an appointment, 212-263-4300. Next slide. So this program that I put on every month with Anya is part of the Center for the Prevention of Cardiovascular Disease. We've been doing this since 2015. We've had over 50 lectures. We record them. They're on YouTube, lots of different topics. And you can find out more about it by going to nyulangone.org/CVD prevention. And for appointments with our preventative medicine cardiologists, It's the same number, 212-263-4300. Next slide. This is how you stay connected to us. I mentioned it earlier, nyulangone.org/heart health lectures. There's the email, hearthealth@nyulangone.org, or through Instagram and Twitter at NYUCVDprevent. Next slide. Thank you so much. I want to thank all of you. These programs are a huge success because of our audience. We've literally had thousands of people listen in over the years when you put them all together. And so it's a real privilege and it's a pleasure to do this because I really believe that prevention is the most important thing. So thank you so much. Anya, thank you very much. Anya Coates, keep in touch with me or Anya if you want to make any suggestions or give us any feedback. And we'll look forward to seeing you on December 10th. Thank you so much, Dr.
Thanks so much, Dr. Goodman and Anya. Take care.
It was great. Bye.
Bye.